This module will provide you with the knowledge required to be an active participant in the specific exercise lab. By the end of this module, I hope to familiarize you with a brief history and evolution of specific exercise and the McKenzie approach, also known as MDT. Definition of key concepts, current evidence for classification and treatment, and a brief introduction to examination and treatment of these patients. In 1956, Robin was an apprentice of an already established physiotherapist who believed that flexion exercises were the cure-all to back pain. Robin's patient, Mr. Smith, happened to come in that day while Robin was working with another patient, so Robin waved to Mr. Smith to head into the exam room where a patient with knee pain had just left. To Robin's shocking and fearful surprise, Mr. Smith was lying on the table with his spine in end range extension. With a nervous voice, thinking he had completely exacerbated Mr. Smith's symptoms, he asked how he was feeling. "Better than I have ever felt," Mr. Smith responded. Without knowing what else to say or do, Robin said that would be all for today and sent Mr. Smith home. From that story came the DISC model, as well as the respected McKenzie Institute, where the method is finding the magic at the end range of movement. Some key principles of MDT we will discuss in lab include that MDT looks at both symptomatic and mechanical responses to movements, postures, and positions. The subjective exam creates a hypothesis that is either confirmed or refuted by the physical exam. That there is a specific progression of forces from fully active or patient-generated to fully passive or therapist-generated, and that MDT leads to a form of self-treatment. We see some of McKenzie's principles of specific exercise being utilized in the treatment-based classification system beginning in 1995. This method of evaluation and treatment is first up in the algorithm published in 2006. In the most recent update in 2017, we see the use of McKenzie's method under the category of symptom modulation. We also see some of McKenzie's methods and principles cited in our most recent update of the Clinical Practice Guidelines for lumbar spine pain. As for evidence of the effectiveness of specific exercise, positive trends exist. We see significantly greater improvements in matched subjects. In fact, in one particular study, 1/3 of the patients in the unmatched groups dropped out. In looking at the ability of McKenzie's classification system to successfully assign patients to treatment groups, studies show that it does at a high rate. However, those patients may be able to be classified in other subgroups of the TBC where they could be treated in other ways. This means that patients could receive both manual therapies learned prior along with specific exercise. Some benefits of specific exercise is it empowers the patient through active movement and management of their own symptoms. It also includes patient education and the concept of symptom prevention. So how do we know who fits into the specific exercise group? This should not be a subgroup a patient is forced into. Rather, the answer should come to you. To determine if a patient would benefit from specific exercise, we use the rich information we receive from the subjective exam, followed by an assessment of their response to repetitive or sustained movements into flexion, extension, and side gliding, both in standing, prone, and supine positions. Patients will either respond by an improvement in symptoms with movement in a specific direction, or they will not improve with movements into any direction. If this is the case, we move on to possibly classifying them into a different group. The patients may be acute to chronic, with a severity of symptoms from mild to severe. They may or may not have lower extremity symptoms or neural signs, and symptoms may be constant or intermittent. They will typically have pain during movement, pain at end range of movement, and/or pain with sustained postures. Before we move too fast into classifying, we will discuss some key terminology to understand. Directional preference is defined by any specific movement, posture, or position that reduces or abolishes symptoms. This is confirmed by an improvement in the patient's asterisk sign, including pain, range of motion, or neuroexam findings. This can include centralization. Centralization is when symptoms move proximally and is considered to be a good prognosis. Remember that and educate your patient that central pain may get worse. Peripheralization is when symptoms move peripherally or distally. Movement in this direction is contraindicated. Centralization is always a directional preference, but a directional preference is not always a centralizing movement. So back to how we determine who fits where. First, we listen to the patient and question for patterns, such as how symptoms respond to flexion movements, postures, versus extension movements or postures. This then gives us a reference on if they prefer one or the other. We then advance to refute or confirm that hypothesis. We do this by putting the patients through movements, postures, and positions to try to work towards holding at end range or repetitive motions towards the end range. We begin with patient-generated movements. Pending their response, we ask them to add overpressure. Based on that response, we offer our overpressure and then shift towards passive mobilization, then manipulation. Patients are considered to have a directional preference if their pain or range of motion improves after repetitive movements or postures. They are considered a centralizer if they centralize with two or more motions in the same direction, or centralize with a movement in one direction and peripheralize with a movement into the opposite direction. Those that peripheralize with all movements are no longer in the specific exercise category, and they need to be categorized in a different subgroup for the time being until we can find movements that centralize their symptoms. During the exam, as mentioned in prior slides, we take a patient through a progression of force and assess response after each. Begin with patient-generated, then patient-generated with patient-delivered overpressure, then patient-generated with a therapist overpressure. Along with progression of forces, we need to consider the gravitational effects in the positions of standing versus prone versus supine versus seated. Examples of how to progress extension are listed in this slide. We will practice this in lab. This slide shows the lateral force progression, which we will discuss in lab. And finally, this slide shows the flexion progression we will discuss in lab. We will now introduce what to make of your findings. We want to consider two snapshots in time, symptoms that occur both during and after movement. We will use a color system to aid in decision on where to go next. This chart will hopefully help you through the examination of this patient. If symptoms are produced or increased during movements and are worse after, stop there and consider moving into the opposite direction. If symptoms increase or do not change, and there is no change after, that is a yellow light. Consider progression of forces, or changing position, or moving into forces of the other direction. If symptoms decrease during and are better after, that is a green light to continue to see if we can take them to their end range with overpressure. We will discuss this in more detail in lab, but so that lab may run smoothly, please familiarize yourself with the content of this slide. Our exam always begins with education of expectations. Specifically, we are telling the patient what information we are trying to assess with these repetitive movements, and that they may experience movement of symptoms from their limbs to their back, which is a good sign. We start with one movement in every direction to get a baseline. We then do repetitive movements up to 10 in standing to determine a preference. We then move them to lying to assess if we achieve the same results as standing. Remember to monitor during and after. We want to empower the patient throughout with education and always consider multiple types of exercise for ease of use when at work or home. Of note, if centralization does not occur, then consider traction. If centralization plateaus, consider your progression of forces. Though giving them movements in the direction they like helps modulate symptoms, to meet the goal of restoration of function, we need to add movements into all directions. But when is it safe to do that? Typically, as severity and irritability decreases and the stability of the condition improves, we can introduce movements into the opposite direction, being mindful of ranges and gravity. Educate the patient on the differences between their symptoms and general soreness from new activities. When starting, end the session with the previously utilized centralization maneuvers. Another intervention to consider when your patient's condition is stable and centralized is the addition of neurodynamics. We will discuss this more late in the semester, but we'll introduce this in the lab. We always want to consider prevention through education. In closing, there are many details in this module, but I want you to respect how specific exercise fits into the big picture. It may be used in isolation or paired with other interventions, such as mobilization or motor control. It also may be a group where a patient does not fit initially. For example, if we cannot get a patient to centralize, we may try other modes of treatment until we can get them to centralize with movements, thus become a specific exercise patient. Thank you for your attention. I hope you find this module helpful in preparation for lab.